Good afternoon, everyone. I would like to introduce you to my PhD topic, investigating the consequences of inappropriate antibiotic use in the intensive care unit. I'm Levente Prácser. I'm an anesthesiologist and educator at the Department of Pharmacology and Pharmacotherapy, also working in the intensive care department of Semmelweis University. I want to live in a world where every physician can access the most up-to-date resources, and my mission is to provide the best clinical evidence possible to help healthcare professionals make the best possible decisions. Currently, I have two specific goals, first of which is investigating the effects of inappropriate antibiotic use on complication rate in the intensive care unit, which will be approached by the method of systematic review and meta-analysis. Inappropriate antibiotic use is not an easy entity to describe. It has many aspects, which can be divided into four main categories: unnecessary antibiotic use, too narrow or too broad spectrum of the antibiotics, and incorrect dosing of the antibiotics. The problem is that inappropriate antibiotic use in the intensive care unit is quite common, between 28 and 46% according to the literature. What we know is that early, ideally within 1 hour, antibiotic administration is recommended by sepsis guidelines, which in part led to the increased antibiotic usage increase globally. Excessive antibiotic use can lead to complications such as selection of multi-drug resistant pathogens. The missing link is we don't exactly know how inappropriate antibiotic use is related to adverse events. And our aim is to unveil if there's an association between inappropriate antibiotic use and complication rate. The graph shows that in the upcoming years, based on a continuous growth estimate, antibiotic use will increase exponentially. So it's a very important question for the future. So with this study, our clinical question is, does inappropriate antibiotic use have an impact on complication rate in the critically ill? We are investigating critically ill patients to the exposure of inappropriate antibiotic use with the control of appropriate antibiotic use, with the outcome parameters of organ damage, multi-drug resistance incidence, Clostridium difficile incidence, secondary outcomes, length of stay, and mortality are the main outcomes with drug-related adverse effects. And our hypothesis is that inappropriate antibiotic therapy increases complication rate. The implication for this study is to reduce the incidence of multi-drug resistant infections and improve antibiotic use in general. We conducted a systematic search in 3 main databases with the keys shown below. And we ended up with more than 3,000 articles for full text selection, which is still ongoing, and the conservative estimate for number of full text is over 300. We are almost done with the full text selection process, but we have some preliminary data sets for specific subgroups. These are preliminary results, so the full analysis is still to be done. This plot shows Acinetobacter infections with the type of appropriateness investigated is too narrow spectrum. What you can see here is that with the random effects model, we can see that there is a non-significant difference between mortality of appropriate and inappropriate antibiotic use with Acinetobacter infections. And the interesting aspect of this is that we can't draw any conclusions yet, but the dogma that appropriate antibiotic use solves all of the problems of severe infections is for the let's say conservatively, it's not the full picture. We still wait for all of the results, and I hope that in the end we have a definitive result. The second project is procalcitonin kinetics guided antibiotic management in patients with septic shock. This will be a randomized controlled trial, and we are drafting the protocol. Sepsis 3 has redefined sepsis as an entity, meaning that it's a dysregulated host response to an infection. What is here we have to define the entity of suspected septic shock, because the definite result that there is an infection comes a little bit later. Septic shock as a clinical syndrome can be either due to infection, so the clinical presentation can be due to the infection itself, but it can also, other hyperinflammatory states can also present as septic shock. These are two different etiologies. So if a bacterial infection causes the syndrome, it must be treated with antibiotics. But if it's the hyperinflammation that causes the syndrome, antibiotics won't help us. So the problem is that the sepsis guideline recommends an immediate, ideally within 1 hour administration of antibiotics, but although it's a strong recommendation, it has a low level of evidence behind it. This leads to the overuse of antibiotics and leads to the increase of adverse events. A recent meta-analysis conducted by Pop et al. Concluded that procalcitonin kinetic guided antibiotic therapy may shorten length of treatment and improve survival. In the meta-analysis, the length of antibiotic therapy was almost 2 days lower in the PCT kinetics guided group, and mortality was 16% lower in the PCT kinetic guided group, although the rate of recurrent infection was a bit higher, 36% higher to be exact. But what we agree with the guideline is, although it's a very low evidence and weak against recommendation of using solely a static procalcitonin value to determine whether to start antibiotics or not. We are not arguing that a static parameter should be used. We are arguing based on the study of Tashi et al. That we use procalcitonin kinetics, so delta procalcitonin, as a measure of the presence of a bacterial infection. What these two graphs show is that in the first graph, you can see that the lined group has no significant difference between the start value and the later value. Meanwhile, the non-striped has a very significant difference. The striped one is the no infection, and the non-striped one is the infection group. And they calculated the AUC value of delta procalcitonin, which was 0.85, compared to other more traditional parameters like white blood cell count and CRP levels, which were on the 0.5, around the 0.5 line. So our primary aim is to assess the effect of PCT kinetics-assisted antibiotic therapy in reducing the incidence of inappropriate antibiotic therapy in patients with suspected septic shock. Our clinical question is whether this PCT kinetic-based antibiotic management reduce unnecessary antibiotic administration and improve outcomes in patients with suspected septic shock. We are examining lower severity suspected septic shock patients. The intervention group is the PCT kinetics guided group, and the control group is the standard empirical therapy group. Our primary outcomes will be organ dysfunction parameters, antibiotic appropriateness, with the secondary outcomes of length of ICU, hospital stay, and mortality. And our hypothesis is that delayed kinetics-guided antibiotic administration improves antibiotic appropriateness and organ dysfunction parameters. The clinical implication for this study being that individualizing antibiotic use by using PCT kinetics approach may reduce unnecessary antibiotic usage and improve clinical outcomes. I want to thank you for your attention with the quote of Theodore Roosevelt, "Nothing worth having comes easy." Thank you very much.
I have a question regarding your first topic. So if I understand well, you want to compare inappropriate and appropriate antibiotic use in septic patients.
Yes.
And my question is, how do you plan to deal with patients whose immunosuppressants? Yeah. Okay. So patients, for example, with HIV infection or lung transplanted patients or things like that.
These patients, although they are not excluded from the study.
Okay.
We are examining immunosuppressed patients as well, but there is a high heterogeneity whether what type of immunosuppressants they are on, so this can vary the results severely. So if we have enough data, the only way we can approach it is whether create a complete subgroup of these patients or even create subgroups within subgroups. With 360 studies, I think it could be possible, but let's see the end result, whether we can do it or not.
Thanks.
I have a small question regarding the first project. How do you objectify the inappropriate use of antibiotics? You showed what types there are, but what are clinical measures to objectively decide?
The studies vary a bit. So meta-analysis, we can only work with what we already have in the literature. The most common one that is reported is they use bacterial cultures of various kinds, either be a blood culture or bronchoalveolar lavage. It varies, but generally based on those, the most common one that is reported is too narrow spectrum of antibiotic use. So it was not, the original pathogen was not susceptible. What is harder to define is the too broad spectrum, because generally these studies consider a too broad spectrum appropriate therapy. We shall see. We shall see with those what comes out. The inappropriate dosing, those are generally speaking ones that are regularly measured. Most commonly vancomycin is reported with CRRV. Patients with continuous renal replacement, and then the drug levels are actually measured, so inappropriate dosing can be determined that way. So these are the options we are having right now.
Concerning this, sorry.
I have a little question. The most exciting part of your talk, Levente, is the serious and the not serious septic shock. How could you define what is not serious, what is serious? It's a little bit hard.
Yeah, the severe, non-severe difference, we had multidisciplinary meetings regarding this question. What we have so far agreed on is a very moderate use of norepinephrine, and a increased lactate level, which is under 4 millimoles per liter, because that's the threshold where mortality skyrockets. So after between 2 and 4, that's the lactate level where we can accept circulatory problems, or we can tolerate it. We can wait a little bit.
Thank you.
Okay, but the norepinephrine levels have been indicated in a very low level with the cutoff for the severe or not severe septic state, or the need of norepinephrine administration. So 0.02 or 0.05, it is a very low level. It is the lowest level that we use.
Yeah. So if it's higher than that, I think it's ethically not cannot be explained why we are not giving antibiotics given the current knowledge if we would wait for patients that require a higher dose of norepinephrine.
Okay, and do you take into consideration the vasopressor or vasopressin or analogs?
So far,
are used?
If we are in this study, the current guideline, the first in line treatment for septic shock is norepinephrine. Other agents, if we have to combine these agents with the use of norepinephrine, these patients will most probably be excluded. So,
of course,
so only the first line treatment we are talking about.
Patients.
Yes.
Yeah, okay. Concerning the second study, will you measure the rate of de-escalation of the antibiotics proven by the microcultures?
If we haven't discussed that, but it's definitely in the picture, yes.
It will be important to take into consideration. Okay,
Thanks for the recommendation.
thank you.
Congrats for your progress. I had a question for your second project. Excuse me if I didn't understand it correctly. But one of the outcomes was antibiotic appropriateness.
Yes.
And since it's a clinical trial, you define what antibiotics you give. And if it's not appropriate, is it ethical to give it in the first place?
If I understand your question correctly, your presumption is that there is a predefined protocol of what antibiotics we are going to give. That's not the case. We are not going to define the exact antibiotics we are giving because it will be based on infection site, based on clinical presentation, based on individual patient data. So because of the vast number of variables, we have to rely on physicians' choice a little bit here in the choice of antibiotics. What we are trying to assess here is if we give an additional tool to clinicians, this PCT kinetics guided antibiotic therapy, can we improve the current state? Now physicians are choosing freely, and in order for us to determine that, we need to give them the opportunity to choose freely as well.
Thank you.